Pleasure of being your moderator today. We have three wonderful guests with us that I'll introduce first, and then we'll have a short presentation from each of them, and then we'll have a nice conversation at the end, hopefully that you can involve yourself in if you like. So as you're going through, if you have questions or things that come up, keep those, and then we can have a conversation at the end. So our three guests here have commonality in that they're all global health practitioners in some way, but have a diversity of backgrounds. So Dr. Vida Mani is with us from the School of Law. She's trained in law and did her law degree at Osgoode Hall. She did a PhD at the U of T in juridical science. At Queen's, she's at the School of Law, but she's also the co-director of Feminist Legal Studies with us, and she's also affiliated with the Cultural Studies program as well. Oyedeji Ayanrinde is trained in medicine. He's an associate professor in psychiatry. He's also the community director of community mental health. He's the director of community mental health at Providence Care. And Deji was also the chair of the Commission on Black Medical Students. And then our last guest is an alumni of our program, actually, MSc in FE, but is also a trained physician, and she works as an associate professor in emergency medicine and our department, public health sciences. Jen is also the population and global health track lead for the Bachelor of Health Sciences, and she also works as an affiliate global health person at OPDES, which is our Office for Professional Development and Educational Scholarship. Another interesting thing about Jen is that she works very closely with Pamoja Tunaweza. It's a women's clinic and center in Moshi, Tanzania, and many of our students have had chances to be involved in that work as well. So welcome to you all. They've been given their marching orders between 8 and 10 minutes each, so that'll give us lots of time at the end to have a conversation. So Vida, if you don't mind, you can start. Oh, that's amplified.
Yep. Thank you for the introduction and for having me, and thank you to Dr. Bradley Stoner and the team for welcoming me here today, and all of you for being joining us for some conversations regarding new directions and paradigms for global health. I had the distinct pleasure of making some of my connections and expansions and networks, both with Dr. Ayanrinde and Dr. Stoner, as well as others, through the Kaleidoscope Institute's initiative, which is our new, upcoming, incredible organization that radically transformed everything, including the vision of how to think about and do global health in a way that is very future-oriented. It's very inclusive. It has proper regard to move beyond research to bi-directional, community-oriented knowledge creation, translation, dissemination, and so forth, and is, I think, part of a very exciting future. But part of that future is also really expanding the conceptual understanding of what we mean when we talk about global health. And we've talked about these things, thank you. We have talked about these things, some of the discussion around that conceptualization, of course, is not new. That is, if we think about the World Health Organization's traditional approach to the social determinants of health and the considerations of the social determinants of health, then we see that the focus really is and should be broader than a strict traditional medical model of health as such. And that's part of the Kaleidoscope's Institute's initiative and the working group vision as well was very much tied to the decolonization of global health, the expansion of the agenda in terms of the Truth and Reconciliation Commission's call for global health scholars to move in that direction and towards more equitable societies generally, both locally and internationally. The non-medical factors that influence health outcomes, of course, are quite significant, and the World Health Organization's position with respect to these is that social determinants can be more important than healthcare or lifestyle choices in influencing health, including things such as income and social protection, education, unemployment, job security, working life conditions, food insecurity, housing, and so forth, all sorts of things. And so that fits nicely because you might think, what can a lawyer have to say? What can a lawyer / law professor have to say about these topics in a meaningful way, especially one who's further specialized, because we can understand law and policy concerns for sure, because they do govern poverty, basic income, food security, all sorts of things. But from an intellectual property law, which is my area of specialty, what can a lawyer have to say in particular? When I came to this in your shoes as a doctoral student in the year 2000, there were two main health controversies that were challenging the government at the time. The first health controversy was with respect to the gene patents over BRCA1 and BRCA2 genes that are linked to the propensity to develop breast and ovarian cancer. At the time, the gene patents and the method for diagnostic testing were held by a Utah-based American company by the name of Myriad Genetic Laboratories. And Myriad sent the government of Ontario and BC cease and desist letters because the claim was that the testing for the breast cancer genes, Angela Jolie genes, you might have them popularly referred to, was occurring in alleged patent violation. So Ontario was doing this for approximately $800 per person. Under license, it would cost about $3,500 roughly per person. You could do the math, the fractional cost in terms of achieving health outcomes. And so the claim was patent infringement. BC discontinued testing for 2 years and redirected their cancer patients and testing to Ontario at the time. Ontario, under the premiership of Mike Harris at the time, made submissions to a committee on predictive genetic technologies, and I was part of the subcommittee on gene patenting to that committee, about how patent law would need to be reformed. Surely genes are patentable, and I'll tell you what patents are in a second, but they're intellectual property rights that are rights of exclusion. So the implication is that, of course, you could do direct-to-consumer genetic testing with the implication that elective mastectomies, double mastectomies with gender disparate impacts, of course, would be had without the proper genetic counseling and ethics that go with that kind of conversation, okay? But in the end, BC resumed their testing, but now with a huge wait list and long delay. Ontario had continued. What would have been the implication? The implication would have been Ontario could have been sued domestically under patents for patent infringement, or the US company could have lobbied their trade representative to bring a complaint against Canada at the World Trade Organization. 150 plus countries are members of the WTO. Pretty well, if you're active, you're part of the WTO. There's universal minimum protections for intellectual property rights that are prescribed as international legal obligations for any member of the WTO. So a patent must be granted without any discrimination to the area of technology for a minimum of 20 years. So patents are rights of exclusion. They're monopolies that are generated for a fixed period of time for 20 years. They generate artificial scarcity, and they have huge health implications. At the same time, there was another controversy in 2011, post 9/11, with the US anthrax scare, in which the threat of bioterrorism was raising issues of potential anthrax outbreak, which effectively resulted in Canada yet again bypassing a foreign patent holder's intellectual property rights. This time it was Bayer Cipro rights, pharmaceutical Cipro medication, to stockpile through Apotex without proper authorization and licensing the generic version of the medication in anticipation of an anthrax scare. Two things came out of this at the time. One, that this discussion of patents in public health is not a discussion relegated solely to this north-south divide, third world developing countries, access to essential medicines, malaria, AIDS medications, and so forth that had occupied such space and generated divisions. In fact, the discussion is inherently one of the human right to health at the highest attainable standard for all, wherever you are, and trade and property rights. The problem was that states would have competing obligations to reconcile under these, because any welfare enhancing decision as a matter of law and policy domestically pursued to prioritize public health could be met with welfare eroding implications and costs of not only being sued domestically, but being complained against at the WTO with carousel trade sanctions being imposed. And as any lawyer will tell you, sometimes it's not a matter of the merits of the case. Sometimes it's about leveraging a case. Do you want to be happy or do you want to be right? So if you have a softwood lumber dispute going on, why not bring another complaint and generate a bit of a political mix into the blend? So in this context, I pursued my activities with respect to the implications, and of course, there's some considerable substantive equalities issues related to this because health includes the right to health on an equal basis, of course. Other instruments that are protecting health in international law. And of course, part of the problems is that the design, these are intellectual property rights, are colonial regimes themselves. So even in their distributional consequences for allocating property rights and who can benefit economically, they have not been just or equitable. So women's traditional knowledge of plant genetic resources has not qualified. Over 23 years of intractable issues regarding the protection of traditional knowledge, traditional cultural expression, and folklore with respect to genetic resources, implications for biopiracy and so forth, extraction, a continuation of the extraction agenda that has ensued. So patents is not the only area, of course. Copyright continues to be a problem area too. And so this is just a headline with respect to the retraction of a paper recently, a COVID-19 vaccine hesitancy paper, that was retracted. Why? Because the authors of the paper used text and data mining for machine learning of a database that was publicly available through the libraries, but because text and data mining was not authorized, the paper was required to be retracted. So there's no consent to. So any innovation in the space to use big data analytics, text and data mining, and so forth is now subject to copyright implications as well. And contractual implications. That is, even when we have traditional rights to books or whatever, we read them, we pass them around, our property rights end up superseding the intellectual property rights to a certain extent. Once we get a book, we can lend it, we can do whatever else like that. We can't photocopy it, but we can lend it. But the implication was this withdrawal of a retraction, and increasingly publishers will impose contractual overrides, even to the detriment of existing fair dealing provisions within copyright law and such. So I'm part of a global user rights network that's mobilizing around these issues. I'm also part of intellectual property scholars. We made a submission to the federal government on the copyright consultation. Okay, on the copyright consultation recently that's underway with respect to text and data mining allowances as fair dealing within copyright law, because the implication is considerable. Innovative approaches to global health, access and other consortium, patent waivers, copyright waivers. So at the beginning of the pandemic, because of the need for access to accelerated research in COVID, there were publishers who waived their copyrights to allow research to proliferate around the common public good concept of health. But again, then once that ends, it ends, and it's always contingent and never, it's always qualified, right? Do you want to be dependent on the charity? So major implications there. My current work is dealing with, we're coming out with a book in December on the Sustainable Development Goals and intellectual property rights. Stay tuned for that by December. Hopefully it'll be forthcoming, looking at intellectual property rights implications for each of the Sustainable Goals agenda. I'll just end by saying the commitment in human rights and the goals is the 2030 agenda is leave no one behind and start with the most behind first, which is inclusive and equitable. But intellectual property rights are, by definition and design, exclusive and inequitable. Thank you very much.
Up there, so that's bringing in lots of things, and I hope giving you lots of sense of global health in the legal arena, and our partners and our colleagues as well. Next, we'd like to have Ayan Rinde, Dr. Ayan Rinde, come up, otherwise known as Deji. Good to see everybody. Welcome.
Thank you very much, Pauline. Thank you for always taking on my full name without a blink or a stutter. It's really commendable. So leave no one behind. Leave no one behind. I speak to you as a psychiatrist who works in the community in Kingston here and with a number of international collaborations. And what I hope to do is actually trigger your reflection on the opportunities in global health that may be out there in some spaces you may or may not consider. If I were to continue Kimasoro on Yoruba, and I was speaking, I'll speak in sense. Now, your inability to understand what I'm saying doesn't mean I'm talking nonsense. And how much do we restrict our knowledge and understanding to those that we understand and therefore make them more credible? And those that we don't understand because their language or the way they communicate, how much do we unconsciously or consciously invalidate them? Now, a lot of global health research ends with beautiful papers, many pages, amazing stats, millions of dollars of work. And so concluding comments at the end of the studies are more research is required, or this work would inform policy in particular areas, or more funding is required for these things. And in a way, it's gone some of the journey, it's shed lights, but what are the work in the trenches? Who does that work in the trenches? And that's one thing I want to touch on, that in some of the work that needs to be done, some people need to roll up their sleeves, be in the trenches and do the work. No one's work is more important or less important in these stages, and I'll give a few illustrative examples. When it comes to community mental health, every single country is developing. No country in the world has a perfect mental health service whereby, using Peter's last phrase, no one is left behind. The wealthiest countries still have people that are homeless, suffering, who don't have access to mental health care. We talk of wealthier countries like Canada. Not every single student or member of the community has access to mental health care when they need it. Everyone is vulnerable to mental health issues and challenges. We don't even have a sufficient medical workforce. And so it's a big issue there, whereby in how do we deliver the mental health care to the population, not talk of more vulnerable people in the population. So I'll give some examples in a world, particularly mental health, where the digital divide with technology and these amazing technological advances are leaving people behind just more and more and more. I'll give some examples. Mobile phone, amazing device. It's pretty much a pocket-sized computer. During the pandemic, guess what proportion of the patients that I serve, the people I serve, had mobile phone with which they could have video consults and access? Roughly what percentage? It's not an auction, just any number. Throw a number at me.
20.
20%, 20, 30. Only 14% of our clients had video conferencing capability. For all sorts of reasons. They didn't have internet, or they didn't even have a device, or they were so ill they didn't believe the device. Some had had their heads pumped with information that 5G was a cause of mental illness and so on. So 86% of the people we serve could not engage in those sort of consults. And it meant we had to innovate. So we innovated in that space. What if we give all of them mobile phones? So we tried to give people mobile phones. Some had not used a mobile phone before. Some couldn't even get a hang of the swiping, the things we take for granted. So even with the technology there are people still left behind. So that's an example. Artificial intelligence. Now AI, we have things like this. And does anyone know what this is? Science is moving super quick. And this is a device I use at least twice a day for monitoring. This is a 6-lead ECG device. I don't mind saying I've got long COVID and I've got some cardiac complications here in my meds. Meds, say hello to everyone. And this is a 6-lead ECG device, which through machine learning then transmits to a database of and will tell me whether I've got abnormal heart rhythm. Within seconds, I can generate a PDF report of my ECG and send it to a critical person. Because I have the financial capability to buy it, I've got the technology, and I can pay to be part of that machine learning cluster in a center in the US. Not everyone has access to this. This delightful device, I'm not trying to hypnotize you, stay awake. This is a pulse oximeter. Absolutely critical to the pandemic, oxygen sats. I mean, we've all been talking oxygen sats, even if not a physician. But do we know that this device is inaccurate with dark skin? Dark skin, dark fingernails with nail polish, it misreads. How long have we known this for? 30 years, 30 years. Did the technology advance to correct it? No. So again, are we leaving people behind or not? Why wasn't the technology invested in these sort of other populations and so on? So these are some really quick illustrations of how you, as public health practitioners, scholars and practitioners, have abundant opportunities in this space. Wrapping up with a final example, we've all heard of cancer, and some of you may be doing work around oncology and cancer care. So imagine if I was psychotic with schizophrenia and I had hallucinations, I was looking around the room, I was paranoid, I thought somebody were trying to kill me with your laser beam eyes and so on, or poison me. How do I go through cancer care? How do I screen? There's an excess of smoking amongst people with severe enduring mental illness. Who puts in the smoking cessation programs? A lot of people with severe enduring mental illness cannot do the traditional standard screenings. Bowel cancer screening, one of the examples is a FIT test. Many of my clients cannot do a FIT test. There's 42 lines of instruction, or you can do web-based screening questions if you have internet access. But how many can do that? If I'm so ill that I can't consent for a colonoscopy, cervical or pap smear, and so on, what happens? Very few people with severe mental illness go through the whole process with cancer care. And you have a 2.5, in some cases 3, between 2 to 3-fold increase in mortality in the sort of population I serve. So we're actually looking at cancer care guidelines for a number of common cancers, trying to see how we can support these individuals with their screening. What do we need to put in place for someone who may not be consented or who may be too ill to understand for the common cancers, breast cancer screening, cervical cancer, colon cancer, and so on. Now, these are just some examples, and ultimately, in public health, you also have great opportunities in implementation science. Doing some of that work that you can say, we did this, and these were the interventions, these were our outcomes. And with that in mind, maybe we can then determine who we choose to let die or not. Thank you.
Thank you so much, Reggie. There. And finally, Dr. Carpenter. So just give me a little nod.
Okay. So thank you so much for having me. And I have to say that when Dr. Stoner asked me to do this, I was like, yes, definitely. And it's, but the last couple of weeks of trying to figure out what to talk about in 8 minutes, I had a really hard time sort of trying to pin it down to an 8-minute talk. And I decided what I would do is kind of talk about mistakes I've made. So I've been working in the global health field since, well, even during med school. And okay, I think I need to go forward, but can I use your computer to click my slides? Does that work? Okay. Thank you. Okay. Okay. Yeah, perfect. Okay, so yeah, so I've been working in kind of advocacy and global health for ever since med school, and so I was like, what do I do? But I know that a lot of students and a lot of my TAs ask me how I got to where I got. And so I thought I'd sort of frame it a little bit like that. I don't need to tell you what I've done because Colleen already did, and thank you for the introduction. But you know, I've had people ask me, how did you end up where you are? So there really was no master plan. Part of that, and so just to make you all feel better while you're sitting here, not being 100% sure where you're going to go with your career, there's no master plan, and you really just need to listen to opportunities, listen to people, listen to the universe. Don't be too focused on the end game, but learn as much as you can and speak to as many people as you can. When I was in med school, we had one session that was called International Health, one session in 4 years. There was nothing about global health, nothing about diversity, nothing about health inequity, or maybe there was about health inequities, but I don't remember it specifically being talked about in that way. And actually, I know there was, because there was a public health course, but the rest of it, though, really very, very little. And so I kind of had to, I knew what my passions were, and they kept coming to me, and I had to sort of blaze my own trail. So, but you can imagine mistakes were made. And it really takes a lot of humility to notice your mistakes, acknowledge your mistakes, learn from your mistakes. And then what I have ended up in the circuitous route doing with my career is teaching about my mistakes, or trying to help other people in the future generation not make the same mistakes. So just to kind of take you quickly through when I was, so me and how I got to what I do. So the stage was kind of set when I was a kid. I grew up in a family of, my mom was like the consummate advocate. She was taking us to peace marches, driving the station wagon to New York City to join 1 million people to march for nuclear disarmament. My uncle spent his entire career in Africa working for the Canadian Development Agency. So I knew that this really interested me. And then in second year med school, we had 2 months of critical inquiry where we had to do some research. So for me, it was like, oh, research, yeah, okay, whatever. But really, I just need to find a way to get to Africa, because I know I need to get to Africa. So I did my critical inquiry in the Ivory Coast, found someone to supervise me. Like, unbelievable things happened while I was there. When I think back to the research study that I created, because my supervisor was clinical and he didn't know anything about research. So I, created this great research project, and I went into the villages and I talked to people who had the health education about HIV, and talked to other people who hadn't had the education yet. And I even stopped by the CDC in Abidjan on my way up to the northern Ivory Coast and got their advice on things. But when I think back at the ethical issues, the safety issues for me, the safety issues for the community, I'll get into that in a little bit when I talk about mistakes, but there were definitely a lot. In 2007, I went to Tanzania for the first time with Karen Yates, and we were volunteering for an organization that did what they called caravans. So we worked really hard for 2 weeks. At the same time, I was asked by Medicine Curriculum to be the first advocacy lead, and so I took that on. And then in 2008, around that time, because the students knew me because I was the director of student affairs at the time, they kind of came and said, this curriculum and this program needs to change. We need a core global health curriculum. We need an office of global health. We need help with electives, a certificate in global health. They were asking for a ton of things. And so I tried to help with a lot of those, and really what I'm talking about now is kind of the help with electives and core curriculum about global health. So Karen and I, around the same time, we started working in Tanzania at a women's center that we started with partners on the ground. That really our theme was empowerment, so prevention through empowerment. And I can talk to you all about my work there forever. Anyone who wants to talk about it, basically what we focused on was affordable healthcare and affordable high quality healthcare and health promotion activities. But as I said, humility is required. There were mistakes made along the way, and I just kept trying to learn from them. So I figure the only way to begin to make up for your mistakes is to recognize them, fix them if at all possible, never make them again, and if possible, help others to not make those mistakes. So mistake one that I want to talk to you about is a little more about that time in Ivory Coast. So as I said, I just want to get to Africa, and I was using this 2 months as an excuse to get there. I found a supervisor, just designed this research study all on my own because my supervisor didn't know how to help me. Didn't have ethics, didn't have community engagement with, I had lots of community engagement as I went into the communities and got them to do these surveys with me, but I didn't ask them how the survey should be done. I didn't work with them. I didn't ask them if they even wanted the survey to be done. And then there are tons of sort of safety issues that happened with me while I was there. Personal safety issues, mental health stuff for me and my supervisor, ethical issues, because there really wasn't anything about training people and helping people do ethical work in the global sphere. So my solution was, as soon as I had the ability to do it, so like when I was advocacy lead, I started creating pre-departure training for faculty of health science students. It changed every year based on the issues that I heard about when students would come back, the things that they told me, safety issues that had happened, things they had noticed that they had done wrong, things they didn't notice that they had done wrong, but I kind of helped them realize that perhaps what had happened wasn't super ethical. I was on the national committee for this for quite a long time, and we kind of got to the point where we had a framework. So like those 5 categories of personal health and safety, travel safety, cultural awareness and humility, language competency, and ethical considerations. And kind of over the time that I was working at the national committee and with the student group nationally, it went from one school in Canada having formal pre-departure training to it becoming an accreditation standard. And then we just kept kind of working on it because students came back and said, yeah, okay, like everything you said before we went away made sense, but I still got messed up. I still felt pressure to do something outside of my scope. First year med student trying to resuscitate someone, that kind of thing. And so we just kept listening every year, hearing the problems, hearing the things. And then we created some simulation cases so that the students actually could, rather than just learning about it, practice getting themselves out of those situations, those ethical situations. And then recently, over the course of COVID, we actually put the pre-departure stuff, which is different than the university does great pre-departure training. But we really felt that for the Faculty of Health Science, for people who are working in the health realm, there's a whole different component of information that's needed in addition to what the university does for you. So we've made it into an online course now. So mistake number 2 was that first caravan. You saw the picture of Karen and I. Thanks. Really excited to be there, but it did not feel good to me there. I wasn't running it. We were rushed. We were told to hurry up because there were so many patients outside. We were working with translators. I didn't know the culture. I felt like I was doing harm to these patients because they thought they'd been seen by a doctor who knew what she was doing. And I didn't even feel like I was like getting at the surface of what the problem was and just handing out Tylenol and stuff. So, and also these patients had no follow-up. I had nowhere to send them. So solution, we did things differently. When we did mobile clinics and healthcare, just community engagement from the start. The communities were the ones who invited us, told us what they needed. We took lead from our partners on the ground, and then consulting. I can't believe, we basically, that first one we went in, I don't even know if the local health authorities knew we were going. It's horrific. So just learning all along. And I guess that's what I would say to you is talk to people, learn from people, talk to the community members, do whatever it takes to make them actually want to share with you. I had community members who shared with me the horrific things that some of our students did while they were there and I wasn't there. But that's how I learned to be able to talk to other people about avoiding these mistakes. So it's about humility, which then, if you're showing humility, the community will trust you and will share things with you that they wouldn't have shared with you otherwise. And that really is the basis for having allyship with these communities, and empowering them to make the change, doing whatever it takes to help them make the change rather than us deciding what the change is needed. So I'm just really grateful to my patients here in Kingston, many of whom don't have a lot of privilege and benefits, for sharing things with me, as well as my friends in Tanzania for sharing these mistakes that I've made, or my students or my volunteers or other people, so that I can really learn about it and hopefully help others learn about it. So what I've been working in lately is that kind of stuff.
Thanks to all of our speakers. So I'm going to start with, I have two questions, and it's just going to kind of come in a bit. As we talk, I'm going to give an opportunity for any questions from the room as well. So be ready for that. But I'm going to start with a question to all three of the speakers. I did not prep you for this one, but as I'm hearing people talk from like lawyers, doctors, I'm wondering if you could talk a little bit about your teams. There must be people who are not medically trained or legally trained. So people from public health, some have medical or legal training, others don't. Tell me a little bit more about your team, what kinds of training people have on, some of the projects, so that they'll have a sense for just the diversity there.
Yeah, thank you. So lawyers and law professors don't necessarily work in sort of a team framework, which is, I think, one of the limitations. Interdisciplinarity is often, if it's found, in particular intellectual property law, comes from law and economics perspectives and such. But I think increasingly the commitment to interdisciplinarity, multidisciplinarity, and a collaborative ethic is quite key because of the need to generate impactful, transformative, meaningful research. And the way you do that is by looking at the effects that are being had within a particular designated community. So right now, for example, I'm on a project out of the School of Computing on AI and triage bots. And part of that is looking towards targeted communities in which AI may be used in the triage context, in the medical health context. And that collaboration is really important. So there's ethicists, computer scientists, myself. There are implications of consent, privacy, EDIIA implications for sure. But also there are cultural implications. So when we look at the increasing use of facial recognition and biometrics for affect detection, there's coding implications, for example, with respect to that. There have been calls for bans. There have been disparate harmful implications in the capacity for AI to amplify inequalities, including, so not only just what Dr. Ayurvedi mentioned, but even with respect to detection of, they call it object detection, there is lack of predictive parity and equality in object detection. What does that mean? That means a self-driving vehicle, so-called autonomous vehicle, will not detect a person with a darker skin. Right? Yeah. So like there are all sorts of implications, or the green technology used in Fitbits, used in over 300 clinical trials. Again, same types of problems in unequal application. So even if you diversify your clinical subjects for your study, you're not going to address these implications. These are tech implications, and then with AI, there's an automation bias that feeds into this. So there's a piece I have here just on AI and equality by design. So short answer is, teams have not historically been part of the sort of legal approach to things historically. I think that's changing. First of all, both within lawyers, there's like mobilization. So we have IP scholars, all like a group of us writing, submissions to the government, mobilizing advocacy effectively on circular economy and Internet of Things. And of course, as we become increasingly cyborged with implants and so forth, the copyright software in our Internet of Things is embedded in our actual being, right? So implantables and stuff like that. So IP's everywhere, everybody. And of course, then across disciplines. So we're planning on collaborating on a piece with Professor Cram in rehab. There's a partnership grant. So these collaborations come, though, once we sort of find each other and we see, okay, what is it? We all care, but there's nothing essential in the structure. And one of the reasons my work started the way it did was because if we characterize this as a, the issues of health and let's say intellectual property rights as a developing countries issue, then we continue to have these false binaries where if we extend what Bell Hooks calls the love of the stranger, if we recognize our common humanity, if we want to make the world a better place for everybody, and that's all in your power to do that. There's nothing essential in the system. Everything is up for grabs. Everything's up for renegotiation, and it's always better together.
Wow.
What she said.
I was gonna say what she said.
It's also really interesting because as we spoke earlier about the digital device, some of the language that Dr. Mann is used so eloquently would be what would be classified psychotic some years ago. I mean, talking of cyborgs and implants and things monitoring you and so on. And that's some of the real world challenge. So I'm talking about our teams and so on. In some of the work, for instance, in oncology space, psychiatrists are not great at oncology, oncologists aren't great at mental health. So you've got those services, you've got people who do smoking cessation work, you've got people who are graphic designers who are able to sort of translate information into other ways people can engage and consume it. But also people experts by lived and living experience. And it takes knowing someone or going through oncology care directly to really better appreciate how challenging these situations are. And we're grateful to some of our experts by lived, living, and deceased experience who have created and supported. In some of the work we do with the homeless population, again, there's so much to learn from people who are living with unstable accommodation. So many things we take for granted. You leave hospital, you've got no address, and you live in a tent. How do you get follow-up? Tree 17 on a Monday and a park bench on a Tuesday, and so on. So the expertise sometimes, and some of the most significant expertise actually in some of our work comes from the non-traditional spaces. A lot of work also involves working with an ethicist, and it's really striking how much moral distress when you're trying to do some of the implementation work and you can't because there are no resources and you feel so guilty and horrible and feel you're failing people. Sometimes it's the ethicist just helping us to reframe and balance that as well. So those are just some quick examples. Thank you.
I know you have another question, so I won't say too much, but I just really want to highlight what both of you said about working together, interdisciplinary, bringing in those other viewpoints and lived experience. And I think that sometimes it's harder to get something done when you're doing it with a big group, to coordinate the big group. But the outcome is so much better rather than just sitting by yourself and trying to top it out. One of the greatest experiences through COVID was working with you, Deji, and the group that we, putting together a curriculum for the racism in health course. And that, it would have been much easier for one person to just sit there and say, yeah, this is what we should talk about. But the stuff that came out of it from working together was great.
All right, just given time, I want to open it up to the room. If there's anyone that has a question or something burning that they wanted to clarify, or anyone online, Nikki can take a look at the chat if there is anything.
Be shy.
Yeah,
Sam,
don't be shy, exactly. There must be some.
it should be a global
peers.
conversation, right?
Sam.
I can do it. So one thing that's been discussed in the 805 course that I'm teaching this term for any second years, we're talking about leading evidence-informed action. And I think this is a really good example of you're kind of living the action of equity in your work. And especially Jen talking about your experiences, how you were open to experiences you didn't necessarily have a plan, but I would argue you were kind of driven by values. So I was wondering if you guys could each speak to what values drive you in your work.
Good question, Sam.
Want to start at that end and we'll go this way?
Sure.
I don't know if I've ever been asked that question before, so thank you, but
Goes for everything.
I think, you know, I was lucky enough and privileged enough to grow up in the family that I grew up in. And I think the values of thinking of people less fortunate, and trying to do whatever you can to empower and to lift them up. I would say that's one of my core values, and I got it from my mom and others.
That's a cracking good question. And I'm processing as quickly as I can, because for the first time you got me thinking, that's actually what binds so many of us that work in this space are our values. And I got mine from my mum and dad as well. Thank you.
So, an iterative process, I suppose, but because really, I cited bell hooks, love of the stranger, love of the other, but that was my mom. I lost my mom in the fall this year, so I'm gonna get emotional, but my mom exemplified the significance of agency. Apathy is never an option. She would tell every stranger she met that she loves them, and then she would intervene. So not everybody welcomed that, but apathy was not an option. So if it's like the Maya Angelou quote, if you know better, you have to do better. You know, you cannot turn a blind eye. You cannot be silent. You cannot accept defeat. You cannot be apathetic. It is always your problem. And that has intrinsically informed, so the ethic of care and universal love as being fundamental to the human condition. And why are we here? For corporate accumulation and wealth through intellectual property rights? Right? No. Why are we here? So I think that value really is fundamental, and I see that through all of us. It's the ethics of care. And I just also wanted to say back to your earth point. You said earlier about being open to opportunity and the universe. And I love that. And I have to tell you, there is no plan. As long as you are driven by the value, there is no plan. I was supposed to do my doctorate at U of T in juridical science on restitution and intellectual property rights. My rookie supervisor got a chair appointment and changed institutions. I had to refine my center. I didn't know what I was going to do. Some guy at the corner of Bloor and Young stopped me. He was yelling, "The sign of the devil is near. It's not 666. It's patent number blah, 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 blah." Wearing a big orange and yellow vest, handing me a paper, stopped me, handed me a paper. And I looked at the paper, and I think I still have it, and it said it was about vitamin A enriched rice, genetically modified rice, to prevent blind in developing countries. Golden rice, thank you. Okay? And here is I at the corner of Young and Bloor. Voila, I have my thesis. And then I started researching gene patents, food security, right to health, right to food, farmers' rights to safe seeds, all those implications that are entailed. And then the more I looked at it, I thought, okay, you know what? There is a there. Be open, be willing, and be loving. And I think it will be good.
And a quick squeeze in also is, when we talk about intergenerational things, so many influences influence what we then do. Chance situations, chance meetings, not everyone has a mom and dad, but we're talking significant people in our lives. And it's really interesting how you've got a panel of 3 people, there's significant people from another generation that have sown the seeds. And that's how trauma and other things also transmit.
Yeah, we're kind of coming to the end here. I do have to say that one of the things I notice with global health people is that there's a lot of value-driven people. And it's an interesting kind of similarity. But you know, the value to me is that every human is equal, and we all have the right to live the life that we would choose. And when you have the lived experience of not having that, or when you are beside people and you know that they haven't had that, and you've been there, it's really hard to just ignore that, you know? So you start to realize, where is my power and privilege able to be applied so that, you know, the work that I do can contribute to that value coming forward for every human. Yeah. I want to thank all our speakers. I know that this room gets inundated with students immediately at the half hour, so I want to give us a chance to come up and chat with people if you're interested in just introducing yourself. Before we do that, I do want to thank you all for coming and spending the hour with us in public health. You're welcome anytime. I know many of you have been here before, and we hope that you come again. And thank you to everyone who came today and participated and enjoyed our time together. Let's give them a round of applause.